Hello and good evening. Welcome to the next episode of the IHC Irish Hypnotherapy Conference specials that we're running here on Facebook in the run up to the conference in Dublin on April 5th and 6th this year. And we'd like you all to come. And that is the reason we're presenting some of the speakers to you. We've already had a bunch and we have quite a few coming up quite a few more coming up. Now, let's get the words out right. And this with me today is Garry Coles, who's going to speak there as well on the subject of, now it comes, psychoneuroimmunology, or PNI for short. I know why they call it PNI because it's way too long to say. Anyway, hi, Garry.
Hi.
You're going to be talking about hypno-oncology today. And first of all, go ahead and introduce yourself.
Yeah, indeed. Hello. I'm Garry Coles. I'm from the UK, about 35 miles southwest of London. I'll give you a little bit about my background and why I'm talking about oncology and touching on PNI. I did actually talk in Dublin last year on hypno-oncology, but rather unfortunately, they put me on at 9 a.m. on Sunday morning after they had a very big dinner dance on the Saturday night. So I had quite a small audience. So perhaps we'll get back to revisit that another time. But this year, as you mentioned, I'm doing psychoneuroimmunology, or PNI for short, and we call it PNI because after you've said psychoneuroimmunology 3 or 4 times, your tongue and starts falling over it. So PNI. So yeah, I'll give you a couple of statistics to start with, and then tell you more about my background. Uh, Cancer in the Western world is getting to epidemic proportions. A lot of people don't realize that statistically, in the Western world, 1 in 2 people born since 1960 will be affected by cancer at some time in their life. 1 in 7 women will contract breast cancer. 1 in 8 men get prostate cancer. Bowel cancer affects 1 in 15 men and 1 in 18 women. Lung cancer is 1 in 13 men and 1 in 15 women. And interestingly, SAGE research actually shows that 40% of cancer sufferers will actually seek out complementary therapy, such as hypnotherapy. Now, in some countries, it's a lot more than that. It's typically 40% in the UK and the US, but it's as much as 70% in places like Australia. So even at that lower end, that means that 20% of the population are going to be looking for therapy, particularly hypnotherapy, to help them go through that. So that's quite a big market of people. 20% of the population could be after you to help them. So why aren't you in that area? It's huge, absolutely massive. But anyway, I'll give you a bit more about my background so that you know why I'm talking about this. I've been a full-time hypnotherapist for just coming up for 20 years. I'm one of the very few people in the UK and I think in the world to actually have a Master of Science degree in clinical hypnosis or clinical hypnotherapy. I did that through the University of West London and I did a research master's and it caused me a lot of ethics problems, but I went ahead with it anyway. But I did some groundbreaking research. I did a study into pre-surgical hypnosis and the effects that had on the recovery quality in breast cancer operations and I was able to demonstrate that it did and how and why. And it wasn't because of my research, but it's quite interesting now that in the UK, the Royal College of Anaesthetists now actually recommend pre-surgical hypnosis. They don't actually call it that. They dress it up as something else because they're frightened of the word hypnosis, but essentially they are promoting pre-surgical hypnosis. And I was able to demonstrate that both physically and psychologically, it did give a better recovery quality in breast cancer operations. So I did that. I've also spent 19 years as a hypnotherapist in an NHS oncology unit in the UK in a major hospital. So in that time, I've worked with around 2,500 cancer patients. So I think I've got a pretty good idea of what works and what doesn't work based on my research and the work there. So over the years, I've perfected a lot of approaches and techniques working with people. Uh, so having worked with that many and having done my research, things sort of then escalated from there, really. People were interested in my research, so I started getting emails, oh, you're a bit of an expert on this, can you give me some advice? That then escalated to, will you do a podcast interview with me? And so that got more emails. And then it really started to really take off about 10 years ago when I was invited to talk at the UK Hypnotherapy Conference, the very first one. Obviously did okay because I've been invited back to speak at everyone since. I was then asked whether I'd like to speak at the world's biggest hypnosis convention, which is in Las Vegas, Hypnothoughts Live. And I'm speaking, I think it's the eighth time I'll be speaking there this year. Then I had a lot of people say to me, you need to put a training course together for this. So I decided, okay, we'll do that. And so I put a training course together, which is available either in person, online, or on a USB card. I've done that since I put the training course together about a decade ago. I've taught doctors in Belgium, I've taught psychologists in Bahrain, so I go all around the world and teach it live as well as online. I have a hypnotherapy script book for oncology, which is available on the website. And I'm just currently trying to do the last three chapters of an academic hypno-oncology book, which is going to be sort of teaching people again what to do with it, but more aimed sort of more academically with the research behind it for doctors and so on. So that was my experience with that. I now go around the world and teach all around the world and speak at conferences. For example, in Dublin, which will be, in fact, that's my second one of the year. In fact, I'm teaching in Denmark prior to Dublin, but there we go. And I believe this year I shall be also speaking in Michigan, Vegas, Chicago, Florida, and other places that I can't think of on the top of my head. And so it seems to have taken off. A few people used to tell me a few years ago in the UK that I was probably one of the top two or three people in the UK on this particular topic. But since I've been going around the world, it's been quite nice that people have been telling me I'm probably in the top two or three in the world on this topic, which is quite nice. So I just want to get the word out there, get people. There's a lot of stuff we can do with cancer patients. Uh, Other things that I do as well as that is in the UK, because hypnotherapy isn't regulated. In the UK, we have the Complementary Natural Healthcare Council that the Department of Health put together. I actually sit on their hypnosis board there, so I'm one of a team of three that is responsible for putting together the national training curriculum for the CNHC for hypnosis, their ethics, and I also sit on boards as a specialist for malpractice cases. Um, so that's pretty much my background in hypnotherapy and particularly oncology. So hopefully that's given a reasonable idea that I do know some stuff about this area, and can talk about it a little bit more. And now, one of the things is, is hypnotherapy useful for working with cancer patients? There is. Because I've done my master's, I come from quite a scientific background, and there is some really good stuff out there that demonstrates that it does, that it is really useful. But one of the biggest things we need to make sure of is that we do not treat cancer. That is the big thing. A lot of people don't realise that in the UK, for example, we have a 1939 Cancer Act. And you can be jailed for giving advice on cancer treatment, for treating people with cancer and doing all sorts of things. So you need to be very, very careful how you word things and what you actually do. And again, that is covered more sort of in the training. So I say we do not treat cancer. What it isn't is we don't do a regression to cause, we don't cure. People going through the cancer journey are absolutely desperate. Uh, and a lot of people will prey on that. And also, because, as well as being desperate, a lot of people are very ill informed. For example, there's some recent statistics from the American Society of Clinical Oncology, and they interviewed 4,000 adults. 25% of them had cancer. And out of those, 40% of them agreed that cancer could be cured by oxygen, diet, and herbs alone. Half of those under 50, the age of 53, and I don't know why they picked the age of 53, but half of those under 53 thought that cancer could be cured by only complementary therapies and nothing else. Now, the worrying thing about that is whether people believe that or not, is that if you actually use complementary therapies alone, that doubles the mortality rate and that rises to 6 times in early stage cancer. So by giving somebody or encouraging somebody to have an alternative therapy alone, will have 6 times more chance of dying than they would normally. So that's not a very good idea.
Now, what we
Um,
need to probably add here is that it's the UK Cancer Act is not necessarily the only legislation that prohibits
It isn't, no.
promising a cure for cancer. Yeah,
Yeah, yeah. I mean, that's the big catch-all in the UK. Now, I know in the US it is state specific in
yeah.
various states. The NGH are pretty good. They have some good stuff on their website, the National Guild of Hypnotists. They have some good stuff on their website about what you can do and what you can't do in the US. And it is different in different countries in Europe as well.
Yeah.
So you need to look in your own area, but in particular. In the UK, we have the 1939 Cancer Act. We also have the Advertising Standards Authority, and we also have a bunch of fun people. The Nightingale collaboration we have in the UK,
Fun
and that
people.
bunch
Okay.
of have you come across them?
No, I don't know. Why
Oh,
fun people?
well, the Nightingale collaboration is a group of doctors and scientists who are very anti-complementary therapies, and
Okay.
they will go around and find people's websites and claims. They started off with homeopathy. That was
Right.
first thing, and their aim is to basically prove that all complementary therapies are complete shams.
Okay.
That's where they're coming from. So
Right. So
they will try and pull holes in anything you say or do to
yeah,
prove it's quackery. Um,
basically it's called complementary because it is complementary,
yep,
and we shouldn't think that to use the famous words, we shouldn't think that we are gods.
yep,
You know,
absolutely.
we're not we cannot solve everything with hypnotherapy or with positive thinking as much as we would like to. And there's always more than one component to it. As much as holistic therapies are great,
Yep,
and if we as hypnotherapists or as any kind of therapist or practitioner take that decision of the person, of the patient, just to get in there, if we tell them do not do this, do not do cancer treatment, then we take the legal responsibility upon us and the ethical responsibility for their well-being in the future. So that's just as a warning to not go all out on what we advise people to do with their
absolutely.
treatments.
Yep. And quite right again to me. Yes, we are complementary. So we do not advise them to move away from standard treatment or anything else. We are there to complement the standard treatment that they're having. Um, but looking at is hypnotherapy useful for cancer journey? Yeah, I mean, a couple of pieces of research. Sharma in 2017 did a literature review of 55 research papers, and they all looked at the clinical benefits of hypnosis with cancer patients, and that concluded that it did benefit them physically and psychologically. And there was an earlier paper from Flammer and Bogarts in 2003, and they did a meta-analysis of 57 random controlled studies of palliative care hypnosis and concluded that it was very effective for many disorders that cancer patients encounter. And hypnotherapy is the number one researched complementary therapy for pain control. There's so much evidence there around the world. So what are the advantages of using hypnotherapy in cancer settings? Um, Reduce costs potentially. One of the areas that my research seemed to show up was a faster recovery quality. So you're freeing up bed space. So that's reduced costs. Also found that medication appeared to be more effective. My research found that people were perceiving less pain a week after surgery. And when we drilled down, not only were they perceiving less pain, they were taking less pain medication than the other group. So therefore, medication is potentially more effective. Therefore, it's more cost effective because they're taking less of it. Less stress for frontline staff. You know, people perhaps going into scanners or just being diagnosed, they might have a full-on panic attack, anxiety attack, and the nurses and the oncology staff can do without that. Whereas we can wade in and assist, so we can take stress away from them. We can give the patients coping mechanisms, more psychological well-being. Um, Another advantage is it's safe. Hypnotherapy done properly doesn't produce adverse effects. Um, Me time, it's enjoyable. It's me time, relaxation. People going through the cancer journey, it's some respite from the fight, if you like, and treatment days. So it's just a nice thing for them to have some relaxation because they're a bit of a cog in a wheel. So it's really nice for them to have that, just that me time relaxation. It can give a temporary or better relief from symptoms. We can empower them, teach them self-hypnosis, and this sort of me time. One of the things that I always encourage, particularly with cancer patients, particularly in a first session, Everybody now seems to want faster and whizzier hypnotic inductions. No, progressive muscle relaxation is a great one for cancer patients. It's gentle, it gives me time, it gives them relaxation. So I would always, unless I'm doing an emergency intervention with a cancer patient as a first session, I always say the first session is the stabilization session. You don't do any work until you have a stabilized patient. So for me, to stabilize a patient, probably at the first session, unless I'm doing an emergency sort of thing, as in sort of they're having a full-blown panic attack, for example, if we're doing general things, then a first session, stabilization, I would do progressive muscle relaxation. I would do some sort of anxiety release and ego strengthening. That gets the patient in a nice, stable place. Then we can go and work from there, moving forward. One of the things that you need to be careful of, particularly in a hospital environment, is be careful on language and approaches to medical staff, because a lot of them don't like what we're doing. Some of them don't like complementary therapies. Um, don't do language or any practices that could be considered new age or controversial. Don't talk about angels and looking over you and all this sort of thing. It's got to be scientific if it's in a hospital. Um, so if it's experimental, you can get away with a lot more. But make sure you package it up nicely on the forms. Don't mention hypnotherapy a lot. Mention metaphorical suggestion, guided imagery, and psychoneuroimmunology and things like that. I mean, a good example that I've used, and it's not something I would say you use very often, but if you did something like past life regression in the hospital environment, you'll be out there rather quickly. But I have found the odd occasion when it's been useful. But if I said, "Oh, I'm gonna do past life regression with this patient," that's just not going to happen, particularly on the forms. So what I've actually done is on the odd occasion when I've done that, the form said that I did a guided visualization utilizing a metaphorical storytelling approach to unconsciously process the patient's narrative. Stick that down, do a past life regression, you get away with it. That's just how you package it. So, and the language communication to patients and medical staff are very emotive. I remember when COVID was happening and I went to have my COVID injection, the nurse saying, "Oh, you might want to look over there because this will hurt a little bit." Well, that's giving really bold suggestion that this will hurt. So you're going to tense up. Whereas if you say, "Oh, you might want to look over there," and you're going to feel a slight sensation, then they don't tense because it's not emotive. They're not getting that idea of pain. So it's very, very useful to be very careful on language. Also, if you're in a hospital environment, you're considered to be another expert, the same as the oncologist and the surgeon, the doctor. Anything coming from someone in authority can be construed as suggestion by the mind. So be very careful on what you say because that can have a big impact. Laughter, really important. Use laughter. People with cancer are still the same people. If they've got a vicious sense of humor or a dark sense of humor, still the same person. So utilize it. Uh, and also, one of the things that you do need to learn is I always say you need to learn about cancer itself. Because again, if you're in the hospital and you're considered to be another expert, if somebody comes into my treatment room at the hospital, somebody will come in clutching their forms saying, "Oh, I've got breast cancer, stage 2, sort of grade 2, stage 4, I'm on Herceptin." And if you look at them blankly, you've lost them already. They're expecting you to be an expert and to understand all the lingo and everything behind it and the science. And so you need to be aware that you're going to know all about that. So what causes it, how it's formed, the terminology, the types of cells that it forms in, things like epithelial cells, lymphatic cells. We have sort of basically lymphomas, melanomas, adenomas, carcinomas, all that type of thing. So we would give a background on those so you know what they are, and
Mm,
so would give a background on the grading and staging, which I'll
mm,
come on to in a minute anyway, because they will expect you to know all that.
yeah,
And again, with things like grades and stages, they're going to be useful from your point of view to know how you're going to approach them anyway, because that will
yeah.
give you more of an idea on the prognosis
I was going to say
and
because
also what you can work with.
yeah, the
Um,
patients are going to come to you like that. If they come to you privately,
yeah,
they're going to tell you all of those things as well. They're going to tell you their whole medical history, probably. Um, quite
yeah.
common.
I mean, the slight difference really is if you're doing stuff in a hospital, you don't get a lot of time.
No,
So
yes.
private patients, yes, you have a lot of time and you
Mm,
can chat through the case history and things. In a hospital environment, you just get the case notes from the hospital, not your own notes that you would
mm,
normally do. And generally, you're time constrained, so they're in your door and with sort of, yeah, I got stage 2, grade 3, blah blah blah. This is what I've done. This is what I got as a problem. Sort it, and you've now got probably 40 minutes in the hospital to now do stuff. But yeah, so we will again in the training, and sometimes when I'm doing this talk, we do talk about the cancer creation, which is known as carcinogenesis. We look at things called oncogenes, proto-oncogenes, DNA repair genes, and suppressor genes, and things like that. But again, that's all in the sort of the training courses and so on and so forth. But we go into that more differently. But grading and staging is a thing that you'll hear lots. And there's a couple of different types of grading, a couple of different types of staging, and there's some specialist ones for different types of cancers. But typically, what it is, we have cancer grading, and that typically goes from 1 to 3. And that is whether they look very similar to normal cells. And if the cancer is similar, because essentially cancer is just a cell that's divided incorrectly. So it's become deformed, if you like. And then it starts to split again and grow and replicate. Now, if we have grade 1 cancer, the cells look fairly similar to a normal healthy cell, and they tend to grow slowly. Grade 2 is unlike normal cells and grow much quicker. Grade 3 is very abnormal and replicate very quickly. And that gives an idea of, and that, basically they find that by looking at under a microscope. They will take a sample and look at it under a microscope, and that will to see how different it is, and that will give an idea. Normally, the more different they are, the faster they will replicate. Is a rule of thumb. And the staging system is basically it gives a way of describing how large the cancer is and whether how big it's grown and whether it's moved to anywhere else in the body. Uh, so typically, and we do get two types of cancer. The other thing that we have benign tumors, which basically do not they grow, but they do not divide. They do not metastasize. That is, they don't split off and grow it into other parts of the body. They can still be dangerous because they can impact on an organ, for example. But typically, as long as they can be taken out or addressed in another way, benign tumors are not quite as bad. But there's a number of staging systems. The most common one is the number one, or we call the tumor node metastases one, TNM system. And that's basically stage 1. It means that cancer is relatively small and it's contained within the organ that it started in. Stage 2 is that it's larger and it may have spread into lymph nodes close to the tumor, but typically it's not spread into surrounding tissue. 3 means it's larger, spread into surrounding tissue and cancer cells in local lymph nodes. And stage 4 means the cancer has spread from where it started to another organ in the body. And that's known as metastatic cancer or secondary cancer. So typically, if it is stage 4, it has moved to somewhere other than the original site. Another myth that we have is what people call things. If you have breast cancer, and it becomes stage 4, and say it may have go to your liver or your lungs, that doesn't mean you now have breast cancer and lung cancer or liver cancer. It is still breast cancer, but it is another organ. So it would still be treated as you would treat breast cancer. So it would be breast cancer in the lungs, not breast cancer and lung cancer. So it's always kept to the name of where it started, because that is the type it is. Now, there's a number of ways we can treat cancer. If it's localized, i.e. not stage 4, typically if it's stage 1 or 2, it's surgery, if we can obviously access that part and it's not limited by organs and so on. You would take the cancer out and a margin around it. Chemotherapy, if it's moved to more than one area, and sometimes they'll do that just in case anyway. Chemotherapy will act with all cells in the body, which is why you tend to lose hair and do other things, because it's hitting all cells that actually replicate, and that moves around the body. Radiotherapy, again, is very targeted into one particular area. We're now doing it using more targeted therapies, and that is where we have special drugs that will actually, if you like, attach themselves to actually the tumor cells, and either be there as a target to allow the immune system to kill them, or will actually kill them themselves. We have hormone therapy, which typically imitates the immune system or either it makes it stronger or it replicates the immune system, so therefore kills the tumors. We have immunotherapy, that stimulates our immune system. And then we have stem cell therapy, which is not normally used. It is actually used for certain leukemias and things, but typically that's used if somebody has a very high grade cancer and they're having probably chemotherapy and other stuff, probably like radiotherapy and chemotherapy together. It really hammers the system. So you would take stem cells out, you would do the treatment, and then you would put the stem cells back to actually start building the body back up. Likely issues, probably a lot of things that you would expect to work with generally. I would find the most likely issues pretty much in order that I work with cancer patients. Anxiety, fear, and worry are the first three things, and that's they're worried over their survival, surgery, side effects, reoccurrence of cancer coming back is a really big one. They're worried about the side effects of treatment, particularly with radiotherapy and chemotherapy. Then we will get phobias. You'll have people worried about needles, might have to have PICC lines, chemo lines, claustrophobia for scanners. A big claustrophobia one is for head and neck cancers. The way they tend to work with those quite often is with radiotherapy, but you have to be very, very still. So they actually cast a mask to your face, which has two little eye holes and two nose holes, and they bolt you down to the table with that. And that does freak an awful lot of people out, mask fitting and being bolted with it to the table. So that's sort of phobias. A lot of it is treatment side effects, things like sleep issues, hot flushes, anticipatory nausea, vertigo, um, sort of pain control, hair loss, eating issues. We work with pre and post surgery issues. With current chemotherapy, is a lot of stuff. Another big one that I'm seeing recently is sort of problems with extremities, fingers, and so on. So neuropathy tends to be quite common. And there is also a chemo drug at the moment that kicks tinnitus off as well, so that's another area. It might be other life issues as well. Cancer can be a wake-up call for other things holding the patient back in life. So quite often you'll be looking at those things. We also provide palliative care. So when there's no cure, we control progress and symptoms. Um, we combine social, psychological, and spiritual support. Uh, if you are providing spiritual support, do understand the patient's belief system. Are they religious? Do they believe in reincarnation, life after death? Are they an atheist or a humanist? I saw somebody asking a question a while ago online was somebody saying, oh, they had a patient with cancer who had a severe fear of death. What could they do for them? And somebody popped up and said, oh, what you need to do is do past life regression, take them to lives between lives to show them how marvelous everything's going to be, how lovely it will all be for them until they come back again. Now, if that's an atheist or something, I mean, I'd want to punch the person's lights out that would come up with that sort of thing to me, I think. So, do make sure their belief system before you start wading in for that. And also be aware that the carers and family should also are included in here, and particularly in palliative care, it's the people that are left behind that quite often need more work. Um, Sessions and approaches are interesting because as hypnotherapists, the majority of hypnotherapists, I do know some that claim they can do everything in 5 minutes, but the majority of hypnotherapists, we do typically do more than one session for a lot of things we work with. In hospital, quite often you will only do a single session with somebody. And quite often that will be what I will call an emergency intervention. It'll be somebody who's having an extreme anxiety or panic attack because they've just been diagnosed or they're just going into a scanner or having a mask fitted. So you will get a lot of single sessions where you're not even going to take a case history. You're not even going to get time to explain about hypnotherapy. You need to wade straight in there and do something. Um, Now, if you're going to pile in there and do something, we'll talk about the sort of things that you can do in a minute. Um, if you do multiple sessions with people, you need to bear in mind that quite often, particularly in a hospital environment, you'll be seeing them on their day of the treatment. So you'll be seeing them before or after chemotherapy, before or after radiotherapy, before or after seeing their oncologists. So be aware that they might be in a heightened emotional state, and also they might be very tired before or after treatment. So you do need to take that into account as well. So sessions and approaches, as I said earlier, the number one thing I would say is stabilize. Stabilize the patient. That is the first thing. You can't do anything unless you've got a stabilized patient. Now, if you need to do a fast single intervention approach, There's a lot of things you can do. You can teach breathing techniques. You can use reframing and distraction. You use submodalities, change, where is this feeling? Change the color, the place, the sound, move it, pull it out. Just pull it out, move it, manipulate it. If you know EFT, you can do that. Fast phobia techniques, other dissociation techniques. Fast phobia technique I tend to use more as a ratifier rather than a standalone technique, because I don't find it particularly permanent. I find it's useful as an add-on. And that's another thing that I had quite an argument with a few people over, and I've had a lot of people everywhere. They say, "Oh, fast phobia cure technique, that's all you need. Fast phobia cure, that's all you need. I do that, it works every time." And anyway, a couple of times I've said, well, no, I don't find it particularly permanent. And so I normally get the reply back as, "Oh, you're obviously not doing it properly. You obviously haven't learnt it properly. You're not doing it properly." And then I say, well, actually, the person who taught me it said that they consider it's not particularly permanent, and sometimes it needs reinforcing every few months. And so then I get the reply back of saying, "Oh, you obviously trained with an idiot. Go and see a proper tutor, a proper teacher." And then I mentioned that it was Richard Bandler who taught me personally, and he told me that. They tend to go a little bit quieter at that stage. So I thought, well, if the guy who invented it says it's not permanent, I'd believe him rather than whoever trained you. So as a first session, stabilization, again, I always go to either a safe place or a comfortable place, a happy place. Let them create it. Post-hypnotic suggestion, I do an emotional release at first session, and then some ego strengthening. That is pretty much good for working with sort of stabilization. Guided imagery is really good for pre and post surgical work. That's where I did my research. Get them to imagine the healing process. Now, one of the things, although we can't work with the cancer, touching on to psychoneuroimmunology, we can do experimental work as long as it's for psychological well-being and we're not actually treating the cancer. Now, I do a lot of work in that area where I do a lot of work with imagining stuff going on with the immune system. We do perhaps pattern work where you imagine the cancer being seen as an overlay that shouldn't be there, and it's gradually being wiped away, taken away. Another little thing I do with people of a certain age is Pac-Man. You remember the Pac-Man game, computer game, going around gobbling up all the cancer cells around the body, things like that. They're all very experimental and only there for psychological well-being. But, potentially it may make a difference. We don't know. There isn't enough evidence. But as long as we're not doing it as treatment, it's absolutely fine. Again, it helps the patient psychologically. So why not? If that's what they want, we do it. A lot of patients see the idea of cancer as a fight and a war. Now, I sometimes give suggestion on that, but the recent research seems to show that looking at it in that way doesn't seem to be particularly useful. Using that terminology is not useful. Um, NLP work, that can be good, forward pacing, rehearsal, swish work, but don't be unrealistic or cause distress. Be aware of their likely prognosis. If somebody has been given sort of, a 90% chance that they're going to die in 6 months, don't get them to start rehearsing how fit they're going to be in 2 years' time. It's not going to be useful. If you're going to use things like timeline and stuff like that, use it to bring resources back to them to help them at the current time. We don't regress to cause or anything like that. A lot of people say, oh, cancer's caused by a trauma. Let's go back and find the trauma and that will cure the cancer. No, show me the evidence. Don't believe any of that. Uh, Parts work, I like. I've got my own authoritarian sort of ego state parts thing, which again is taught in the training. And I find that very, very useful, particularly because it's very authoritarian. I know exactly where the session's going to go. I don't like traditional parts work because it goes all over the place and can be very time consuming with parts negotiation. I've got one that I can guarantee that I will do the entire session sort of explaining, which really sets up the mind to do what I want it to do when I want it to do it. And then we actually do it. And basically, the way I do it, it gives the patient no wriggle room whatsoever. I know exactly where they're going and what's going to happen, and have full control over it. So that's great when you're in a hospital environment with no time. And again, regression, yeah, you might want to use that for going to causes for phobias and things, but not for the cancer. And don't do anything like that on a first session. Stabilize. That's the big thing. Again, come back to communication. It's really important. Use their phrasing, see it their way, use their own belief system. Be congruent. If you're not, you'll get found out. Use their view of the world. And again, I've had problems with this where I've got things wrong. I mean, sometimes I just get people coming in just wanting a nice guided visualization because they want a relaxation session, guided visualization. And I remember, and I try and get them to create as much of it as possible. And I had one came in, they said, "Oh, I want to walk around the garden. Can you take me on a guided visualization around the garden?" So I did a sort of a visualization of the garden, and I thought, oh, just for fun, I'll put different colours in. I was using some of the chakra colours and things like that. And I got to purple, and I thought, rather than having another plant, I thought, oh, it's a purple butterfly. So I got them to imagine a purple butterfly, and they interrupted me straight away, saying, "No, no, no! You'd only get a purple butterfly in a tropical garden. Mine's in a temperate zone, and there wouldn't be a purple butterfly there." So I've completely wrecked their idea of the garden. Um, so let them much of that. I mean, like the beach scene, for example. Lots of people like to have a beach. Um, don't start saying, "Oh, what lovely golden sand." They might be on a rocky beach that they went to as a kid on holiday, so you completely wrecked it. But do use what you have as well. And coming back to the idea of the beach scene, I had one particular session I was doing where that's what all the patient wanted. They wanted a guided visualization of being on the beach, which was great. It was working very, very well until the point it was a hospital day and there'd been a major road traffic accident and the helipad was out of use that day. So they brought in some patients from the road traffic accident via helicopter, air ambulance, and it decided to land next to my therapy room. So I'm trying to do the therapy with this bloody great helicopter landing next to me. And I'm thinking, and it was so loud. And I just thought, no, I can use that. So we were on a beach scene. And I just said, oh, and there's the Coast Guard coming down to make sure everybody's safe and can have a lovely, relaxing time and become even more relaxed. And again, didn't interfere with the patient whatsoever. It just enhanced it because that's the way it goes. Uh, one thing that I would beware of in hospital, and I won't give examples on that so much. Again, there's some in my courses on the training. The worst phrase I hate to hear in hospital is, "We booked a patient in for you. The counsellors feel it'll be a good idea." That normally means that as a patient that has had loads of counselling, completely failed with it. Now, oh, we'll bung them onto the hypnotherapist. We'll let them sort it out. I had some very interesting ones, to say the least, on that one. In fact, no, I will give one on that one actually, because this comes back to a talk I did last year about at the UK thing about thinking outside the box, and it was the first one I had from the counsellors where we think it would be a good idea. And I had a counsellor phone me up and said, "Oh, we've got a." I said, "You're the hypnotherapist. You deal with fears and phobias, don't you?" And I thought, at last they understand what we do. And they said, "We've got a lady with a phobia. Can you deal with it?" And I said, "Yeah. What is it?" And she said she's got a severe fear of sleeping. She's frightened to go to bed at night. And the background to it was she was a very religious Eastern European lady. She'd had an operation. She'd reacted to the anaesthetic, and it gave her hallucinations. And the main hallucination she saw was herself dead in the hospital bed. And she thought that was a premonition. So she was frightened to go to bed to the extent she had to be sedated to get her into bed at night. And they said, "Oh, could you work with this lady? Because she's got this sleep phobia." Now, they didn't tell me the background at that stage. I just had, "Oh, yeah, I got sleep phobia." And they brought this lady in. She's wandering around my office. And instead of sitting down, I thought, this is a bit strange. And I said, "Oh, what's going on?" Walking around my office. And they said, "Oh, her phobia's got a lot worse." And I said, "In what way?" And they said, "Oh, she's frightened to sit down, relax, or close her eyes." And I'm thinking, perhaps they don't understand totally how we work. So, and okay, yeah, we can do eyes open and all the rest of it. But that time I hadn't been doing it that long. And so I thought, okay, how am I going to do this? And I ended up saying to the lady, I said, "You're frightened to close your eyes." And she said, "Oh, yes, yeah, I can't close my eyes. It's frightening." And I said, "It must be really, really painful for you." And she said, "What's that?" I said, "Well, never blinking." And she said, "Oh, no, I blink. I blink okay." And I said, "Oh, is that frightening?" And she said, "Oh, no, because that's normal. Blinking's normal, so I can do that." And I said, "Okay." So I said, let's time you. How often do you blink in a minute? Let's time you. So we timed her, and I said, "Well, if you blinked an extra 2 or 3 times a minute, would that be any more frightening?" And she said, "Oh, no, I could do that." And I said, "Well, how about we blink every time I click my fingers?" So we did that, and we built it up slightly more. And I said, "When you do blink, how long do you blink for?" And I said, "Just show me." And I said, "Well, if your blink was twice as long, would that be frightening?" And she said, well, no, I could do that. And I said, well, let's try it. And you can probably see where we're going with this. Eventually, what I did was I got her blinking more and more times a minute for a longer and longer period of time until we got full eye closure without any fear and panic whatsoever, because I hadn't asked her to close her eyes. We were just blinking. So it was just, again, just reframing and sort of, how it works with people. So those are pretty much some of the stuff on there. I'm going to touch, what am I going to touch? Yeah, I'm going to touch very briefly on PNI, because this is what I'm going to be doing in Dublin. Psychoneuroimmunology, PNI, it's the study of the effect of the mind on health and resistance to disease. It looks at the interaction between psychological processes and the nervous and immune systems of the human body. It was really coined by Dr. Robert Ada, and he did a lot of work with a guy called Nicholas Cohen. They coined the phrase psychoneuroimmunology, and it really looks at how feelings and emotions affect the immune system. And there is a lot of scientific evidence, there's a lot of papers that demonstrate how feelings and emotions affect the immune system. Now, we know that talking therapies such as hypnosis can affect feelings and emotions. So if we take that full circle, the work we do can have an impact on the immune system. Um, Now, and there is a lot of evidence. There's a lot of scientific evidence that shows that, and obviously, with a lot of cancer work, having quite often things like depression, anxiety can impact the immune system. Obviously, certain treatments impact the immune system, so there are things that we can do to counteract that. And there's also experimental work that we can do to actually improve the immune system. Um, so I'm going to be talking a lot about that in Dublin, about the research behind it and the work that I do with it. So that's pretty much. And other things I always let people know about with sort of hypnotherapy generally is I get a lot of people asking me about tips, tips on how to do things, or what are my best tips for working. And the ones I always say, particularly for sort of newer hypnotherapists, always have a plan B, C, and D. That's the first thing. So you always have something there in case the first thing goes wrong. With that, whatever happens, ensure that the patient thinks that was what was meant to happen. So if plan A fails, they should be made to think that that was what was meant to happen, so that you
Mm.
then move on to plan B. Um, I always used to say the biggest thing you should have is confidence. But I would now back that up, that I would actually say intent is the biggest key to me, but you have to have the confidence to back up that intent. And what really brought that to me was a case I did, it was either last year or the year before, I think it was about 18 months ago. I was doing a Zoom session, and the person particularly wanted a regression session to root cause of something. I just started the regression. I got her back to the point in time where she needed to be, and she moved and pulled the microphone out. So I lost all sound. And I thought at that point, she's just got back into it, just gone in the regression. What am I going to do? She can hear me, I can't hear a thing from her. So I thought, well, I don't want to abort the session because I've got another client afterwards. I haven't got time to restart it. What am I going to do? And I thought, I am confident enough. I'm going to do the whole regression session based on facial movements, facial expressions. And so I did my bit, and I could sit and I was asking questions and she was answering them, but obviously I couldn't hear the answers, but I was just basing it on her facial expressions. Eventually, I wrapped the session up. I did some processing, did some inner child work, wrapped it up, brought her back, and I said, "Oh, can you just check your microphone connections?" She put it back in. I said, "Oh, how are you?" And she said, "Oh, that was absolutely fantastic." She said, "You absolutely hammered it. You really resolved it." And I was honest, and I said, "Oh, I'm really glad," because I said, "You knocked the microphone out." And I said, "I couldn't hear anything you said, and I based the whole session just based on facial movements and expressions." And she said, "Well, you absolutely nailed it." She said, "It was a brilliant session. You resolved everything that needed resolving." So I think that was just because I had the intent that I could do it, but I had the confidence of knowing that I could do it. So I would say that. And the other one that I like, and this is not one of my tips. I don't know how many know a lady from New Jersey, Melissa Tears. Not to be confused with Marissa Peers from the UK, who's just very good at marketing. But Melissa Tears is a very, very good therapist from New Jersey. And because she's in New Jersey, she talks like people from New Jersey, which is quite, if you know people from New Jersey, you'll know what I mean. And her one is particularly sort of newer therapists that are worried if they're script based, they might get the script wrong, or they got the technique in the wrong order, or something like that. And her number one tip is, remember, people, we just make this shit up. And that's so true. It's the client has no idea. for what's going on. So again, as long as you have the intent, you have the confidence, and you're congruent with it, they are going to have absolutely no idea at all. So so I'm probably going to end it there and just okay because I've realised we're going for about an hour anyway, and just open it
Not
up if
quite.
anybody has any questions.
Yeah, go ahead. I mean, I didn't get a question in sideways, which is didn't quite need to. But if anything's open for you guys, put the questions into the chat. Um, I did write down quite a few things. Um, right. So carers and family, you only touched on very, very
Yeah.
briefly. What kinds of sessions do you normally do for them? Or what are their issues normally?
Again, it can be a lot of things. The thing that I don't do, which I will put out there straight away, is if their loved one passes away, I will not do grieving
Yeah.
stuff with them because that is a very specialist area as far as I'm concerned, sort of grievance counselling. So that would be going on to the counsellors.
Hmm.
But quite often I will look at things like their fears. That generally they tend to be stressed, worried about losing them, the fears and the anxiety. So it will typically will be much more sort of dealing with feelings and emotions for
Yeah.
them.
Mm. Okay, and we have a question here. You mentioned start with getting the client balanced. What do you stabilized? What do you mean by
Stabilized,
that? Yeah.
stabilized. You can't work with somebody, well, you can work because we do that sort of thing. What you don't want, if you're going to work on fears, phobias, or long-term stuff, perhaps you're going to do PNI work and so on, you need the patient in a stabilized way. We don't want a patient that's panicking, fearful, anxious, and so on. So to me, you need a stabilized patient. Yeah, so unless you're doing an emergency intervention where you've got to do something, to me, stabilization is the first session. You would be very gentle. So I would do a progressive muscle relaxation. I would do some form of emotional release, sort of normally fear, anxiety, um, inadequacy, those types of things, and then some sort of ego strengthening, like white light ego strengthening, something like that. To me, that would be then get you, if you like, a stabilized patient on an even keel that isn't overly emotional or anything like that. So that now they're in the ideal state to continue doing work on whatever you need to work on.
Yeah. You need them to be able to focus on what you're actually wanting to
Yeah,
work on and not on their fear. Yeah.
yeah.
Okay. Can you quickly name what you do in the sessions after stabilizing? Oh, yeah.
Oh, well, that depends on what I'm working with. I work on the whole journey. So the types of things I'd work with is I would deal with the psychological fallout from the original diagnosis. Then there might be fears and phobias for machines, claustrophobia, and stuff like that. I do pre and post surgical work. We do pain control. Probably the biggest area I deal with is side effects of treatment. Things like anticipatory nausea, sleep issues, all that type of stuff. Then we look at palliative care and moving them forward into the future. So really, what comes next is really would depend on what I'm working with. Typically it would be suggestion, post-hypnotic suggestion for something I'm working with. Then I might do quite often I would do my version of parts therapy, sort of the combination of parts therapy and ego state therapy because I find that very powerful. Um, if it was fears or phobias, we might look at regression to cause, something like that. So we might look at an emotional detox. We might do clearance protocols, all sorts of things we do depending on what we're actually working with.
Mhm.
So, but
Next question. Do you have to be a clinical hypnotherapist to do hypno-oncology?
depends what you classify as a clinical hypnotherapist, I guess. It's one of these, just a title, isn't it? Isn't it? I mean, I call
Yeah.
myself clinical and medical hypnotherapist, but then, my master's degree says clinical hypnotherapy on it. So, I would say that I probably am. So, but no, anybody again because it's not regulated in the UK and in various other parts of the world. As long as you adhere to things like the Advertising Standards Authority and the 1939 Cancer Act, anybody can work with cancer patients. I mean,
Mhm.
I would hope that you would sort of know the background to it. You would have had really good training, and hopefully you've done my training, so you know what you're doing. But pretty much anybody can do it.
Um, Oh, I have a question as well because we have lots of people here. We checked before the session who was there in the audience and what they came for. So there are quite a few people who would like to help friends, who would
Mhm.
have family members who might need help. Um, so outside of a clinical setting, outside of the
Yeah.
hospital, um, what can they do for their friends, for their family, to help them cope?
Okay, it depends obviously on their knowledge and background
Yeah.
of therapy
Yes.
and oncology. Again, the first thing, it sounds a really glib answer, but I get a lot of people come to me and say, I've got a friend going through the cancer journey. What can I do to help them?
Yeah.
My standard answer to that is ask them what they would like you to help them with.
Yeah. Well,
Like, be patient led.
yeah.
Don't assume. They might want pain control. They might want you to deal with anxiety. They might want something experimental to do with PNI. Ask them what they would like help with. That is always a good starting point.
Yeah.
And for resources on that sort of thing, obviously you can see behind me, hypno-oncology.com is my website. On that, there is both online training and a USB based training course. They're both currently half price because I was promoting them for a couple of other talks I was doing. So they're currently at half price at people that would like either training on a USB card, so you get to keep it and reference it whenever you wish, or just an online version, which
The
you get to
online
go to.
one.
Yeah.
Okay. Let me
Uh,
put that into the chat.
Yes, in fact, it's hypno-oncology.com. I think it's slash online is for the
Online,
online
yeah.
stuff.
I'll
And
put that link into
yeah, and it's
the
slash
notes as well.
products for the
Yeah.
other one. Now, the products is a USB card version. There is also a hypno-oncology script book there. And not really mentioned there much, I also do a monthly mentoring session, which is not just geared to oncology, it's oncology and everything else.
Mhm.
That's coming to an end actually next month, and then we're starting another year. And there's not only me, I have a guest several months of the year, and we've had people on there. We've had a doctor talking about aphantasia, which is not being able to visualize. I've had a doctor friend from Hungary talking about past life regression research. Recently, we had people asking me about doing inductions on Zoom. So I had the Elmans actually on teaching that sort of stuff. So we've got lots of great stuff lined up for the next year. So again, if people are interested in that's something that they can contact me about.
Mhm.
Um,
Will you
um,
be bringing some of your book, some copies of your book to Ireland?
I will. I need to get some more printed because I think I'm
Ah,
down to the last three copies.
oh God.
So I need to get some. I got through rather a lot at the UK convention, so
Wow, pretty
I will
good.
get some reprinted and bring some out with me. I won't be bringing the Hypno-Oncology book. It's an academic book, so I haven't finished that yet. That's got about another three chapters, so that certainly won't be ready in time. Um,
Right.
one of the things I will bring, I give I mentioned case histories. I give a very positive case history because they're all nice. It was quite a hard sort of. Well, I've got a couple of hard cases, but there's some quite nasty ones which I'll save for the training rather than
Mm,
depress everybody today. But we'll sort of finish with a nice positive one. As one of the patients I had in hospital, she was 29 years of age. I think she's 28, 29, had a very active lifestyle. She was into parachuting and all sorts of stuff, very active. And she was diagnosed with colon cancer. She was told that it was going to be, that they didn't think it had spread very much. It was going to be keyhole surgery. She'd have a really quick recovery, get back to doing what, her lifestyle. They opened her up and found that it had actually a lot of it hadn't appeared on the scans, and it had actually spread throughout her colon. Was very, very serious. They had to remove her entire colon. She had to have a colostomy, and because it had spread, they had to break all her ribs on one side to actually get at everything as well. So obviously, she then came out of surgery, was in a huge amount of pain and a huge amount of shock because she wasn't expecting any of that. Um, they then, because it had spread, they had to give her high dosages of chemotherapy. She reacted to that and died twice and had to be resuscitated. And that's when I was called in. She was in a hospital bed, obviously in a real panicky state, a huge amount of pain, not being able to sleep, and all sorts of other stuff. So I started work with her. We started doing some work on the pain control. Then we started doing some work on the sleep and made some inroads there that were good. It got to the stage where she was discharged from hospital, so she was still coming to see me as an outpatient at the hospital for various related issues. And then I didn't see her for quite a while. And the last time I saw her, it was a couple of years after I'd seen her in hospital. But the last time I saw her, she came to me as a private client for sports performance. She wanted me to help her with her triathlon performances.
wow, well done. Yeah, there you go. It can go well. And that's another question we have here from Lara. I don't know if I missed this question, but thinking about beyond pills and potions, and for anyone who doesn't know this, there's a book by Steve Bierman, MD, Beyond Pills and Potions, who's an MD in the States who recommends hypnosis for medical environments and has obviously written this whole book about it. So how do you navigate around prognosis when people have been given estimated time frames how long they are going to live?
Okay. First of all, actually they don't tend to do that nowadays
Oh,
in the UK, because coming back to the idea of the prognosis can be taken as a direct suggestion if it's
yes,
given by somebody in authority. And the chance if somebody says you've got 6 months to live, that will have an impact on your immune system and all
exactly.
sorts of other things. And you will probably die in 6 months because that's what you've been told and that's what your body's decided.
Have you read the
What?
book?
No, I haven't.
Because
Um,
that's exactly what it says in there.
Right, okay, no, I haven't, strangely enough. But what they tend to do now is they give you statistics, and they give you survival statistics. So it's normally sort of so they'll give whatever it is, say prostate cancer stage whatever, and it will say, oh, 40% of people with this diagnosis survive for 10 years or more, or this percentage. So okay, it might be all 10% of these people with this live beyond 6 months. So it's sort of a roundabout way of giving you the dire prognosis, but not directly.
Yeah.
Um, so yeah, and generally, obviously, I don't give them the prognosis. So sometimes they will come in to me and tell me their prognosis. But again, we'll say, well, and I always say that what you need to do, and again, it's on the training, is you pay attention to the diagnosis, not the prognosis, because the diagnosis is based on facts and research. The
Hmm.
prognosis is just statistical
Yeah.
stuff based on hearsay.
It's an average, isn't it?
Yeah,
Really? Yeah.
yeah,
Okay. Yeah. Oh, sorry. Healing Beyond Pills and Potions.
yeah. There you go.
Yeah. That's the book name. Um, any more questions? They told my friend she wouldn't go past 12 months and she didn't. Yeah.
Yeah, there's a good
Well,
example. And again, being told that, I would suspect that again there'd been a psychological impact with the immune system. That because you'll be stressed and anxious about it, and so then the immune system becomes sort of down regulated, which means that you've got
yeah.
more chance of the disease spread. It's not something that's been totally proven yet, but there's I can't think off the top of my head what it's called. Tumor necrosis factor is in the immune system,
Yeah.
and that is there to basically fight against cancer cells. But there seems to be some indication of it that if somebody is getting sort of close to death, once they get very depressed and anxious and all sorts of other things, it's almost as though it switches and says, right, stuff this, we'll just let the cancer take over and finish stuff. So almost as though it switches. Now, there's not total evidence yet, but that does seem to be the indication behind it.
I would like to have those studies from you, please.
I haven't got the study. I've heard anecdotal
Oh, you've
evidence,
heard
but
anecdotal evidence of a study,
yeah,
have you? Okay.
yeah.
Right. Um, okay. And the next question is, can you talk briefly on what types of techniques you might use when dealing with PNI? Do you work on suppressing cortisol levels, etc.? Psychoneuroimmunology is more a theory, isn't it? Or well,
That
a
that
framework.
yeah. There is some good research about things about components of the immune system that have been modified using hypnosis,
Hmm.
actually in PNI. And yeah, there is research on that. Things, for example, that it's been shown to be more effective than hay fever medicine, for example. And in one particular sexual disease as well, it's been more effective than the drugs for that. So again, there is a lot of evidence for that. And again, there are a lot of different techniques you can use for it, but generally they're based on post-hypnotic suggestion, sort of PNI stuff. Control room of the mind, for example, is a pretty standard one that a lot of hypnotherapists will be aware of. That's the sort of thing you can adapt for PNI, or just post-hypnotic suggestion, direct suggestion. In my book, there's a lot of suggestion for the immune system on different ways of imagining it and looking at it and communicating with it.
Yeah, and the Pac-Man or the
Yeah,
the war, as you said, that might increase stress levels again. That's what I wanted to say earlier,
yeah,
as you suggested as well, or just what many people do, whether people are spiritually inclined or not, is a healing light or a healing energy. That's a lot of hypnotherapists use that, and yeah, looking into the future if you're not working with cancer necessarily, but with something else, with some other disease,
Yeah,
then looking forwards towards the future and seeing themselves
yeah,
improving. That
yeah,
helps
absolutely.
because your mind doesn't know
Mm.
what you make up and
Yeah, that's it.
what your
Yeah, yeah.
actual
Imagine stuff
reality is.
differently. Yeah,
Yeah.
as long as they haven't got a very bad prognosis, obviously.
Yeah. Well, yes. Um, right. What's the book called, please, Maggie? Sorry, I was already distracted there.
The book one is
Products.
Hypno-Oncology. It's a script book. The one is here. I don't know if you can see that.
Yeah. Up.
Hypno-Oncology. It's the same as the background, so you can't see it. It's Hypno-Oncology.
Sorry, I'm putting
Yeah,
the link into the chat. I'm so sorry.
yeah. Hypno-Oncology, hypnotic interventions for the cancer journey.
Yeah.
It's 130 pages of oncology-based hypnosis scripts. And the academic book will also be called the same thing. It will be Hypno-Oncology
Yeah. Right.
when it's finished.
So it's amazing how it all disappears.
Yeah,
Right. Does anyone have any more questions? Because if you don't, we will continue on.
yeah. And I would just say a mention on the book that you can't find it on Amazon. The current one is only available at either conferences or on my website. So
Why is that? Is there a reason for that?
um, yes, it was at the time because before I started writing my academic book, I didn't really know a lot about publishing and so
Ah,
on. So I just, rather than going through all the self-publishing thing, I just went to a local printer and said, I want a load of copies of this book.
right,
And then the book got bigger and bigger, and but I stayed down that route. So
right.
probably what I'm going to do is when the academic book is out, that will be published properly. Um, it will be well, it won't be just on Amazon. It will be published properly because I've set up a
Right.
publishing arm. So although it will be self-published, I have a publishing arm that will do that. And then once that's out there, then once I've sold the next lot of books that have printed, then that will probably move to be published as well.
Oh, superb. Wonderful. Okay. Right. Let's move on to a shameless plug of the Irish Hypnotherapy Conference, shall we?
Yeah,
Yeah.
it's really great. I was
Because
there last year, and it was great fun. It was great learning, great learnings, and a lot of fun as well.
yeah, well, and did we mention fun? So if you would
And
like,
there was some alcohol involved, I seem to believe.
I can't remember. No, joking. Um, right. So the thing is, Gary knows a lot more than he told us here. He's got a lot more stories than he told us here in this 1 hour, 1.5 hour time slot. Um, both on oncology, on psychoneuroimmunology, and he has a vast experience with actual clients, you know. So, correct? Yes, you've been working
I
in
think
the
I've done
field.
more than 10. I've done
Did you
more.
say?
I've worked with 2,500 cancer patients. I believe I've done more than 10,000 sessions with other people.
Well, that might qualify you to talk over a beer or two with anyone who comes to a conference. No, it's going to be a lot of fun, and you are going to learn a lot more than just from online sessions, from this session. And this has obviously been um, a shortcut version of the actual presentation that Gary did last year, and that he does at other conferences as well. So, and lots of presenters are going to be there who are just like Gary, not as much into the Guinness, but um, but still willing to talk to you for I don't know, give their time and speak to you and give you advice and just yeah, just socializing and networking. And thank you both so much. I have to go. All right, thanks Maggie for coming. So yeah, do get your tickets and do come to Ireland, to Dublin, on April 5th and 6th. And that's, well, yeah, in April 5th and 6th.
Yeah,
Sorry, my brain's
and
still not
I would
working.
say come a day or two early and stay a day or two late, so we can again go exploring and
Oh yes, you're
have more
coming in
fun.
on Wednesday, aren't you? Yeah.
I'm doing Wednesday to Wednesday, I believe. Either
Wednesday to
Wednesday to
Wednesday. Oh
Tuesday.
yes, that's right. Are you doing one of the post-conference workshops then? There's
Yeah.
he just enjoys the Guinness so much. Anyway,
Yeah.
um,
I'm just looking. What am I? Yeah, I arrive on Wednesday the 2nd and I fly back on Wednesday the 9th.
okay, so Gary's always looking out for company. Uh, And if that is you, if you have questions, then you can ask him 1,000 questions and he will answer. Same as other, as I said, same as other presenters. Everybody's there, everybody's nice, everybody's kind, and everybody's going to help you get a move on with your stuff, with all your questions, all your issues. So, okay, no more questions. Thank you all very much for coming. Did you all enjoy it? Did you all have fun? You learned a lot. Okay, thank you. That was great, really valuable. Thanks, Garry.
Well,
And I'm going to stop the recording now. If anybody wants to ask some questions in private now, that can happen. So see you all soon. And everybody watching the replay, thank you very much for doing so. Bye-bye.